Welcome to today's episode of AudioBoards, the second episode of our Intern Series, your crash course through the most common hospital conditions. Today we're talking about opioid withdrawal, what it actually is, why it feels so intense, and how modern medicine approaches treatment. Because a lot of people hear the phrase opioid withdrawal, but don't really understand what's happening inside the body. The easiest way to think about it is this. Opioid withdrawal is basically a massive rebound reaction in the nervous system. Opioids act like a comfort dial in the brain and body. They reduce pain, anxiety, stress, heart rate, even gut activity by activating mu opioid receptors. Over time, though, the body adapts. It starts depending on the drug to maintain balance. So while opioids are suppressing stress systems, the body compensates by increasing stress chemicals like norepinephrine in the background. Then suddenly, when the opioid disappears, the calming effect is gone. But the stress system is still firing at full blast. And that's withdrawal.
So the body basically overshoots in the opposite direction?
Exactly. Clinicians sometimes describe withdrawal as a state of hyperarousal. Everything becomes overactive all at once. Patients experience anxiety, agitation, sweating, goosebumps, tearing, runny nose, nausea, vomiting, diarrhea, muscle pain, rapid heart rate, high blood pressure, and intense cravings. A lot of people describe it as the worst flu of their life mixed with a panic attack. Now, an important point here, opioid withdrawal feels horrible, but unlike alcohol or benzodiazepine withdrawal, it's usually not life-threatening in otherwise healthy adults. The major risks are dehydration or aspiration from severe vomiting.
And there's actually a predictable pattern to how withdrawal unfolds, right?
Yes, organizations like the American Society of Addiction Medicine and the World Health Organization describe withdrawal in a fairly consistent timeline. One memory trick clinicians use is the phrase wet and wired. Wet because patients develop excess secretions, tearing, runny nose, sweating, and wired because the nervous system becomes hyperactive. Early withdrawal symptoms usually start about 6 to 12 hours after short-acting opioids or around 30 hours after methadone. At first, it can look almost like the flu. People yawn constantly, sweat, tear up, get anxious, irritable, restless, and start craving opioids intensely. Then symptoms peak around 72 hours. That's when the GI symptoms hit hard: nausea, vomiting, diarrhea, abdominal cramping. Muscle aches and bone pain become severe. Pupils dilate, tremors appear, heart rate and blood pressure rise, and patients often develop goosebumps or piloerection, which is actually where the term cold turkey comes from.
So when somebody comes into a hospital or clinic, how do clinicians actually measure withdrawal severity?
They usually use something called the Clinical Opiate Withdrawal Scale, or COWS score. It's an 11-item assessment that looks at things like heart rate, sweating, tremor, pupil size, GI symptoms, restlessness, anxiety, bone pain, and tearing. And this becomes really important when starting medications like buprenorphine. A critical rule is that buprenorphine shouldn't be started too early. Patients generally need to already be in mild to moderate withdrawal, usually a COWS score of around 8 to 12 or higher.
Why does timing matter so much?
Because buprenorphine binds extremely tightly to opioid receptors. If someone still has a full opioid agonist sitting on those receptors, and you give buprenorphine too soon, it can abruptly displace the opioid and trigger what's called precipitated withdrawal, which feels dramatically worse. So clinicians wait until objective withdrawal signs are clearly present.
What's considered the standard approach for treatment now?
Modern treatment is really built around three pillars. The first and most important is opioid agonist therapy. That includes methadone and buprenorphine, which are considered the gold standard. Buprenorphine is a partial opioid agonist. It activates the receptor enough to suppress withdrawal and cravings, but it has a ceiling effect on respiratory depression, which improves safety. It's often combined with naloxone in formulations like Suboxone to discourage injection misuse. Methadone, on the other hand, is a full opioid agonist. It's highly effective and usually provided through supervised opioid treatment programs or inpatient settings. Both medications don't just reduce withdrawal, they also improve treatment retention, reduce relapse, and lower overdose risk.
And what about people who either can't or don't want to start methadone or buprenorphine?
That's where the second pillar comes in: alpha 2 adrenergic agonists. These medications target the norepinephrine surge directly. Lofexidine was actually the first FDA-approved non-opioid medication specifically for opioid withdrawal. Then there's clonidine, which is commonly used off-label. Clonidine helps reduce sweating, rapid heart rate, anxiety, and high blood pressure, basically calming the autonomic nervous system. The downside is that it can lower blood pressure too much, so patients need monitoring. But it's important to understand, clonidine is not a replacement for opioid agonist therapy.
And then there's the third pillar, what some people call comfort medications, right?
Exactly. Withdrawal treatment is often very symptom targeted. For diarrhea, clinicians commonly use loperamide. For nausea, medications like ondansetron. For muscle pain and body aches, NSAIDs like ibuprofen or acetaminophen. And for insomnia or anxiety, medications like hydroxyzine or trazodone are often used. So clinicians are basically treating each symptom while also stabilizing the underlying nervous system. And I think one of the biggest misconceptions is that detox alone equals recovery. Withdrawal management by itself is not definitive treatment for opioid use disorder. The goal isn't just getting somebody through a few miserable days. The real goal is long-term stabilization, reducing cravings, preventing relapse, lowering overdose risk, and helping patients stay engaged in recovery. That's why medications like methadone and buprenorphine are so important. They don't just treat withdrawal, they save lives. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.